Hello and welcome to the third in a series of video productions that we've done for medical professionals working with their patients with dementia. Today's topic is safety and quality of life, and it really extends beyond medical professionals, so we hope that you'll share the link with family members and other caregivers who are caring for folks with dementia at home. We hope you enjoy this production.
Well, I think one of the things to remember is that regardless of what it is, whether we're talking about a treatment that we're going to do or just interacting and having a good time visiting with someone, that the most important thing is the relationship. We have to remember that the relationship is primary and be less task oriented. Even if the task is a fun thing, we want them to do something with us, we can't focus on the task, we have to focus on the person. So we have to remember, first of all, that the relationship is primary. So one of the important things, and I learned this from Teepa Snow, who's a leading dementia educator, and that is to greet before you treat. Whatever the treat is, greet before you treat. Make sure that you get that connection with the person. The person is actually primary. So focusing on that will make almost anything that we try to do with the person have a more positive outcome.
A healthcare professional can first have a conversation with the patient early in the disease to help identify what the patient's quality of life goals are. Many times what we as professionals or providers think is important are not what the patient has in mind. Many times their goals include functional ability through the disease process, but there are sometimes other goals, including hobbies that are particularly important to them, social interactions, involvement in sort of spiritual or faith community. There are different things that different people will find important. And so identifying what this particular patient or the patient that's in front of you, what their goals are, or what they think is quality of life, defining that with the patient, that is first the most important thing. And then taking that information and including that along the way as the disease progresses. Small tricks or different things that we can teach the family include breaking down a complex task, for example, into smaller steps. Allowing the patient adequate time. A big thing that families have to understand is patience and being patient with the loved one. And that a task that may have taken 1 minute previously or earlier on in the disease process now will take 3 to 4 or 5 minutes to complete. And that not to rush the patient, as that impatience sometimes will fluster the patient or, potentially can cause, outbursts in behaviors or emotional responses that are not, pleasant.
I think as healthcare professionals, we have to give them some ideas, a number of ideas, because they're not going to all work. If we can help people, just take it one step at a time. And then the other thing that I think often we do is we give them a whole bunch of different things and give the impression that you got to do all of this at once. We usually are better at tackling one thing at a time. So maybe we don't start out with 10 things. Maybe we start out with 3 and say, maybe pick one. And here are some ways you might start this one. But remember that we're all different, and we can be overwhelmed if there are too many. We can be overwhelmed if the steps are too hard. We can be overwhelmed if we think, I have to get it perfect from the start. So I just think we have to be a little bit more patient and know that this is something that is going to be an ongoing education. It's not a one size fits all and one time serves the whole purpose. We have to keep at it. Shared decision making is an effort for us to move away from the model where we as healthcare providers tell people what they ought to do. For one thing, I think shared decision making starts way early on. We should have started the shared decision making a long time ago by encouraging people to think about what are my wishes. I think we wait too long to let people to start asking questions about what people would like. I think it's important for the healthcare professional to initiate the conversation. Really important. And again, early on, don't wait till things are difficult. When things become difficult, then it's almost too late. So I think that's part of it, is to initiate the conversations early and be honest with people and let them have that opportunity to make decisions. Well, in shared decision making, we need to look at the issue that's involved. What is it that what is the issue that we're looking at? What does the person want to do, or what is the decline in the health, or the thing that is not occurring that needs to be occurring, or whatever the issue is. What is the issue? What does the person, or sometimes their care partner, want? What is it they would like to see happen? What are the risks that may be involved if they either don't take our recommendations, or they're not able to do it, or whatever? But what are some of the risks that may be involved in all of the options that we're going to lay out before them? Because we need to give them more than one option. There generally is more than one option. There may be a best way, but there's often two or three other ways to get at something. So looking at the issue, what are the risks? What are the options that are out there? And explaining, which options might work best and all of that. But at the end of the day, they're going to have to come up with which option they think not only they like best, but they think they actually might be able to do. Because some of the options that we offer, they really don't feel capable of doing. And then I think one of the difficult things for us with shared decision making is to remember that people have the right to make bad decisions. That's really hard for us. And then there comes an aspect of negotiating risk. Depending on where we're working, in some settings, negotiated risk agreements can be a way of making a shared decision. And also, clearly explaining the risks of the decisions that they're making, especially when we don't disagree with it. I think going down that road in some settings is useful.
Lifestyle modifications, just day-to-day practical advice that I give patients and caregivers. Exercise is very important. Physical exercise improves blood flow to the brain and therefore helps the disease process, and also improves mood, different aspects of the psychosocial interface. The other thing is keeping a routine. I feel like with with Alzheimer's patients, it's important to have a day-to-day routine. Practical things like making appointments in the morning to avoid emotional meltdowns, or just not being able to complete visits or get out to the visit because the patient has tired out, or maybe has some level of what we call sundowning in the later hours of the day. It's just the routine is very important, I feel, and sometimes not as talked about in a patient visit, but definitely as the disease progresses and the caregiver is more responsible for the patient in terms of the day-to-day functioning, I feel like that is an important aspect of that. And that includes things like meals, making sure that meals are scheduled, and bathroom breaks sometimes also need to be scheduled as the disease progresses. These may seem like simple things, but they are actually very needed practical pieces of advice. Diet is very important, a very nutritious diet, well-rounded, all food groups, avoiding excesses of things important, and then taking into account of the other disease processes, obviously diabetes, blood pressure as well. But the other thing is, as the disease progresses, sometimes the patients won't eat on their own, and so you do need to encourage small frequent meals to get the nutrition in. They may fill up faster, for example. So having the small frequent meals allows for the calorie intake for the day. And as the disease progresses in later stages, sometimes it's important to add back things like nutrition shakes to supplement calories, because these patients do lose weight. As Alzheimer's progresses, weight loss is one of the things that we're looking at as something that needs to be addressed.
Well, of course, just staying healthy improves quality of life, but that gets to be difficult sometimes with our folks with dementia, and keeping them safe is really important. So we have to think about how do we help them to stay as healthy as possible, but also how to stay as safe as possible. So some simple things that we can do, for example, when sleep becomes an issue, and sometimes that becomes an issue, not only for them but for their care partners, how can we help them maintain their circadian rhythms so that they stay in a better rhythm for sleeping at night instead of trying to sleep during the day and then we don't get any sleep? So how can we ensure that they get sunlight during the day, that we open the windows, open the blinds, open the curtains, and all that sort of thing? Let light in. This is just a simple thing. Thinking about other things that just offer a healthier lifestyle, getting them to move around, that can be hard. There are times when they just want to sit all day. And how can we get them to get up and walk with us? So again, focusing on the relationship, I would love it if you would take a walk with me. Could you walk with me just around the house, or let's take a walk around the block, or just anything to get them moving. And then there are times socialization becomes a very important part of maintaining a healthy lifestyle. If you just isolate it all the time, that makes everything worse for anybody, whether you have dementia or not. Depression sets in, all those kinds of things. So how can we encourage socialization? We tend to isolate, we tend to stay home because we're afraid that the person that we're going to take out with us into the public may have a behavioral issue, may have an accident, any of those kinds of things, and so we don't go out. We've got to figure out ways to go ahead and do it anyway, bring family and friends in, but prepare people. Let them know that there may be a behavior. There may be something said. They may do something that makes you a bit uncomfortable, and we have to help them understand why that happens and do a little bit of education with them in advance. Because if we don't do that, not only will we self-isolate, but our friends will stop coming. There are some barriers for people to access the resources that are available. So I think the first thing is that we as healthcare professionals really need to work hard at learning what the resources are. And there are places to go to get information like that, but we've got to take the time to do it. And that's a problem. Area Agency on Aging and the Alzheimer's Association are really two good places to start, but there are lots more services even than that, and so we just need to take some time to learn what the resources are. Then when you look at what are barriers for the people who need the services, then you've got things like transportation. That's a huge one. There are services available, but can I actually access the service if I don't have my own vehicle? Does public transportation get me there? Do I even live in a city that has public transportation? And then when you talk about finances, well, some things are all private pay or, good insurance, and some things are income-based. And unfortunately, one of the problems is that I may make just a bit too much, and that's really an issue. So we have to look at what are the resources to help people, especially those that get caught in the middle like that. How can we help them afford services that they really can't afford? So accessing services from a financial standpoint is really, really difficult. So that's when social workers, I think, can be extremely helpful, because they're usually really good at helping people be aware of the various services that are out there and the funding sources that are available. And then health literacy. How do we access services for people? How do we give them information when they're really not very literate in terms of health care? What's their reading capacity? Unfortunately, we have some people who really don't read well or don't read English well. We've got a lot of folks for whom English is not their primary language. So do we have enough educational materials that are available for them in the language that they speak? Or do we have people who can translate for them and talk with them and help them understand? Just because I read the words doesn't necessarily mean I understand it. So we've got to make sure that they're not just reading something or not just watching a video and say, yeah, I watched it. Did they really comprehend it? So that's a very slow process, and it takes a lot of time. For people who live alone, this is a huge need in almost every community around now, because 60% of the people with dementia live in the neighborhood. They live down the street from us. So we have 60% of the people with dementia living in our neighborhoods, 1 in 7 living alone. How do we even know who those people are? That's part of the problem. We don't always know who they are and where they are. So we have to rely on other services that give us information. For example, Meals on Wheels is a really good resource to find out who are the people with dementia that live alone, because they may already be delivering meals. So finding out who the people are who live alone with dementia is a huge area of concern. One of the reasons, again, for Dementia Friendly America, that's a big deal. If we can train people in our communities to recognize the signs of dementia, it may then dawn on them that my strange neighbor down the street, they're not strange. They may just have dementia.
Unfortunately, this is becoming a much more common issue that many clinics, primary care homes are having to deal with. The patient who is living alone and doesn't have the support in the home. Many times you're finding resources for the patient either through insurance, if they have the ability to have home health come out to them, or formal caregiving support, be it other community agencies that might be available. So this is where, as a provider, you have to be a little bit more versed in what's available in your community, relying on resources. It may be things like Alzheimer's Association, it may be 60 and Better, it may be things that, organizations that are geared toward the older patient. So many times the patients who live alone or are on their own do come to appointments by themselves, or they're missing a lot of appointments. They come to appointments not prepared. You may have asked them previously to bring medication, and this time they've come without anything with them, or they're not very clear. It becomes very obvious when you're reviewing medications when they're not clear about what they're actually taking. And it's not a simple question, are you taking your meds? Because many times that answer is yes, but it is actually going through the list of medications and identifying if they take it the way that it was directed for them to take. And then you'll identify holes pretty quickly. And then, sometimes it's the report of other people that like the other members of the care team, the social worker, the nurse, who has suspicions.
Well, I think when individuals live alone, obviously it is good to go out into the home environment and really assess how well they are managing in their home. Are they able to take care of those basic needs? Are they safe within their home environment? I think if there are any concerns with regards to that, we like to make those suggestions about how to change them or connect them with community resources that might be able to help come in and make some modifications to the home and provide appropriate services. If there's a really high, level of concern where maybe they don't have access to those resources, or maybe they're refusing those resources, and you're concerned about their safety or their loved one's safety, we will bring in adult protective services at times, because sometimes, again, just getting it documented that there is need, oftentimes they'll help connect them with the needs, or if need be, help them find alternative living situations, which maybe, again, an individual doesn't know how to seek that out on their own.
It's very important to recognize that aging in and of itself produces changes in terms of our perceptual ability, changes that occur in terms of, for example, our vision, our ability, day-night vision, our ability to recognize perception. All these things change as we age. But more importantly, with the person who has dementia, is the changes that are age-related are magnified to a great extent. Changes that occur in terms of sensory processes with dementia are not simply a decline in those senses, but it's a decline in the ability to interpret the information that comes in from those senses. This is one of the reasons, for example, that many times we'll see a patient who has what we consider to be hallucinations, but they're really misperceptions of the environment, and they verbalize this misperception, interpreting, for example, shadows as being people, interpreting different aspects of changes in the environment as indicating something is going on, delusions, for example, which occur frequently. But that's, again, because certain areas of the brain have changed, especially the frontal lobes, where the ability to take the information that our senses give us and make sense out of it in an appropriate way is affected by dementia.
So with the focus on safety, first of all, I would say everything we do is about safety. When you're dealing with people with dementia, you have to keep in mind that one of the main deficits that people with dementia develop is a deficit in judgment. With that in mind, the way that we assess that is, first of all, very important, get a history from the family or from their prior care partners. And so that gives us a basis. And then the nursing assessment, they do a head-to-toe assessment to identify any kind of physical problems that could be contributing to their difficulties with ADLs. And then if you're fortunate enough, as we are at the West Center, to have partners in physical therapy and occupational therapy, then we make that referral because they can do a much more in-depth assessment. And finally, I would say that it's just very important that you pay attention and listen to the bedside caregivers or care partners. The CNAs that work with these people on a daily basis from the very beginning are going to notice things, both their strengths and their weaknesses, that you might not pick up on a brief assessment. Some of the problems that people with dementia have is interpreting what's going on around them, but also naming objects. And say the part of their brain that is responsible for language may still be intact. And so they may be able to look at something and say, that's a toothbrush. But the connection that tells them what the toothbrush is used for may not be quite making it. And so they may pick up the toothbrush and use it on their hair. Or the little tube of toothpaste that we might hand them so that they can do their oral care. They may be perfectly capable physically of doing their oral care, but that little tube of toothpaste looks just like the eye cream that they had at home. And so all of those things are safety issues that we have to keep in mind all the time when we are assisting them with their ADLs.
Yeah, loss of sensation as well as medical issues can really impact postural control and balance. For sensory inputs, we rely on vision, somatosensory, and vestibular inputs to help us with stability. Adults tend to rely on vision, especially to assist with that. And in early stages of dementia, yes, we tend to see that there's this reliance on vision. But actually, as dementia sort of progresses or becomes more severe, there's less reliance on vision and more on somatosensation and vestibular. The problem is that our vestibular inputs are not usually our most reliable ones, especially as we age. So in environments or with tasks where visual input or sensory input is skewed based on the environment, the amount of lighting or the instability of the ground, and we're having to ask them to rely more on vestibular inputs, this can be more destabilizing and lead to instability. Modifications for persons with dementia can really help to enhance their functional abilities as well as their safety. One of the things that we see is decreased grip strength and fine motor control really impairs someone's ADLs, both with aging as well as with dysfunction. And so there are things that you can do to widen someone's grip or to give them tools that allow them still to be able to open jars or bottles, or even maybe to be able to manipulate things like buttons and zippers. And so those are available. Modifications with assistive devices can also assist improving someone's independence and safety, but we tend to like to try and pick the least restrictive assistive device so that they can still maintain a high level of function. But we can also modify things in the home as well to improve safety. So those are things that definitely we want to consider to meet both the needs of the individual as well as the need to support the task and the environment that they'll be performing it in.
tools that can be used by practitioners across different levels of care are dependent on the cognitive level and the functional level that you're concerned with. So in the acute care arena, one of the tools that is being used is the activity measures for physical activity post-acute care, which is called the AMPAC. And this looks at multiple tasks with regards to low level with bathing and dressing, and even up to higher levels with transfers and mobility and walking. Another one is the Acute Care Index for Function, which looks at similar tasks as well with bathing and dressing, but also can look at issues with regards to incontinence and feeding and things of that manner. When we talk about higher levels of function, there's also historically tools used by occupational therapists that will look at basic ADLs first of all, which is the CATS Index of Activities of Daily Living, and it looks as well at things with regards to bathing, dressing, toileting, and basic transfers and mobility. To look at more instrumental activities of daily living, which is even higher, is the Lawton instrument for activities of daily living. And this looks at even higher functions with regards to their ability to prepare food, to manage their finances, their medications, transportation, and so a long list of more higher level functions. With regards to physical therapy, when we're looking at even higher function, we look at things like gait speed, or we'll do a 6-minute walk test or a time sit to stand test. And these all have correlatives to their level of independence as well as fall risk, and can be very informative with both giving quantitative measures as well as qualitative measures. Well, to really address issues with regards to safety with mobility and being safe within their environment, it's really important that we look at components of strength, of balance, of flexibility, and for endurance to really be effective in improving stability during tasks. So with a person with dementia, if you can even work these components and elements within a specific task and within that environment, that can really help them to kind of either relearn or to perform some tasks that they've performed prior with success. Sometimes in working with patients with dementia, it's good to apply a technique such as what they've termed errorless learning. And errorless learning occurs when you take through certain elements and it allows someone to continue to work on that task and maybe improve their mood during it, lessen the amount of frustration they may get during the task, as well as really helping with them in encoding and retrieving this information later on. The steps in the sequence in this is to apply sort of a no guessing approach. First of all, you allow them to continue to try and find the answer to the task or the question that you're asking, but if they aren't able to retrieve it, you go ahead and provide that. But you also utilize other approaches with kind of a stepwise approach. Sometimes the task can be broken down into steps, and so if you can work it in more of a sequential fashion, allow them to feel the success for it, that is helpful. You can provide a sort of mirror or modeling with that, so that if you can break down the task again into steps and model how the task should be performed, that can be very helpful to the individual. And then trying to banish the cues. We sometimes give visual and verbal cues to an individual as they're trying to learn a task or acquire a new skill. And so sometimes to provide those cues is needed, but to fade them out as they start to be successful with each sequential task or step of it. And then lastly is that spaced retrieval. So you want to give them the time to be able to perform or retrieve the information, but continue to try and span that time that you allow them to work on it. If they need that help, step in and give the support, but then to return to trying to increase that time with the retrieval time that you allow them to perform it, so that they can again encode this information, and that is what kind of drives what we call implicit learning. The goal is for them to be successful at the task and to perform it in an appropriate and in a safe manner. So sometimes what we want to do is be able to, because with dementia we have a difficult time taking explicit information in, those facts, that information. And so what we're trying to really do is force implicit learning, which means that we're trying to allow other parts of the brain to be able to recall and to pull that back out. So if we continually provide the answers too soon and we don't give them time to sort of tap on that implicit learning or that memory, then we don't allow it to become encoded. Well, healthy behaviors to help reduce risks for falls, it tends to be things that, regular physical activity routine. Again, if we can have routine to our day, that sort of establishes expectations of what's going to happen. A multi-component physical activity program, kind of as I discussed before, is good because it allows, again, that activity to be stimulating all the senses that we need to be stable. I think the components of good nutrition are obviously going to enhance physical well-being as well as comfort, and a sleep routine, regular sleep patterns, and are going to again divert any issues with regards to fatigue that might lend to issues with agitation or challenges with confusion.
As far as the eating goes with people with dementia, we do anticipate in the normal course of the disease, their appetite is going to be less. They're going to have more difficulty taking in nutrition through the mouth. So what we have to understand to begin with normal aging, our taste buds are less sensitive, and so they may develop liking for more sweet things than they ever did, and that's very upsetting sometimes to health conscious families. But it all has to do with just the normal progression of the disease. And then another thing that we often don't think about when we're considering the process of eating, it is entirely a voluntary process. Chewing is voluntary, swallowing is voluntary, and so none of that is helped by our autonomic system. It's all voluntary muscle control, and it's all a part of our cognitive process. And so as our cognition decreases, fortunately, eating is an overlearned habit, and so we can help them to remember how to eat by doing the things that will remind them what they're there for. So if someone's sitting at the table and the food is in front of them and they're just sitting looking at it, we can't automatically assume that they're just not hungry. They may just not have a clue what to do with it. But if we can stimulate a little bit of an overlearned memory by what we call a hand-over-hand technique, putting the spoon or the utensil in their hand and using our hand to help them start that motion, then it can get the process started, and that subconscious memory will take over and they're able to help themselves that way. And then we also have to just understand that as this disease progresses, this is the normal, it's the normal cycle of life. With medication management, always you have to know for sure what it is that you're trying to target. So that's the very first thing. But the most important thing about keeping the management of medication safe is to be very well aware of what is normal for your resident, so that you can watch for any changes. And of course you want to watch to see if the medicine's working. So you want to monitor the efficacy of it, and so you want to see how it is affecting the behavior that you have targeted for it. But in addition to that, you want to notice any other kinds of changes in personality, changes in sleep cycle, in their physical, how much they're walking or if they are more unsteady with their gait, if their appetite changes. All of those things are things that you have to monitor with a new medication, because at some point, even if it's working, you have to make a determination about whether or not the side effects that it's causing, you have to weigh the benefits and the risk of it. Pain management for people with dementia can be a real challenge, because very often they aren't able to communicate to you, hey, I'm hurting. They may not even know that the discomfort that they're feeling is because of pain. They just know something's not right. And so for people in the early stages, there are several different scales that we can use. The numeric scale is one scale that can be used very early on in the dementia process. And then we have the FACES scale. Almost everyone has seen that, where you can show faces that indicate different levels of pain. So the one that we use most often is the Pain in Advanced Dementia scale, and that's actually a care partner assessment. And so we look at things like how they're breathing, whether or not they're saying things that indicate pain. Ouch. We look at their body language to see if they're guarding an area or something like that. We look at whether or not they're able to be consoled from the pain. So that's how we can determine where on the scale it is. So somebody that's not in pain isn't going to need consoling, so we'd call that a 0. Someone who is a little bit in pain, you recognize the symptoms of the pain, the facial grimacing and all the breathing pattern change and all of that, but you're able to distract them from it, and so it's probably not as severe. But someone that's in severe pain, all of the distraction, you're just not able to console them at all. And so that's how we rate, as a care partner, the level of pain that they're in. And then, of course, we address it with different methods. If there are ways that just repositioning, things like that. There's different topical medications that you can use for common types of pain, like arthritic pain. Sometimes they're just not able to communicate to us at all a source for their pain. And so the best thing for us to do is to routinely treat. If they are able to tolerate an over-the-counter pain medicine like Tylenol, give it routinely twice a day and see if we see a difference in their behavior or in the indicators that we consider to be indicators for pain. Sometimes it takes something more intense than that, and so we can go to things like tramadol or an opiate like hydrocodone or morphine, depending on what the level of pain we have assessed. And we know their medical history as well, what things are going on with them and what we would typically anticipate to cause a lot of pain. When we suspect that someone is experiencing something like anxiety or depression, we do have some scales that have been proven to be pretty effective in assessing those things. The geriatric depression scale is a self-report scale that's widely used, but it's more effective for people in the early stages. And then we have a Cornell scale for depression and dementia, which is another care partner scale. And we ask these questions based on what the care partner has observed in the resident, and then we can make a determination. Neither of those are diagnostic tools, they are assessment tools, but it can help us in determining whether or not someone could maybe benefit from like an antidepressant. A lot of the symptoms of anxiety and depression overlap, and so those two depression tools are ones that are widely used even for assessing for symptoms of anxiety.
I think in working with patients that have cognitive decline, it can be very rewarding in the fact that you can make an impact of allowing them to sort of return to engagement in society, engagement with their family. And so really educating caregivers and loved ones on how to approach that. The biggest challenge is communication. There is frustration when you work side by side or you live side by side with someone and you're repeating the same answers over and over and over. So by giving loved ones maybe a different approach to maybe providing some feedback or to getting a task done, I think sometimes it's just that little bit that can make a big difference.
So the secondary patient is the caregiver. Many times asking how they are doing as part of the routine visit is important. But more formally, there are caregiver burden scales that are developed. Alzheimer's Association has one. Various different organizations have a self-report tool. Caregiver burden often is also called caregiver stress. Many times it is sort of the emotional impact of taking care of a loved one. This issue is significant as it has significant health consequences for the caregiver. Many times it is noted that caregivers have a higher incidence rate of chronic health diseases, including coronary artery disease, cancers, mood disorders such as depression, anxiety. There are also financial burdens. Many times caregivers, because they are out of the workplace for a significant amount of time, there is a long-term impact of their caregiving in later life in terms of what they would put away into Social Security and retirement. So there really are some significant impacts on a caregiver related to caregiving. Best practices I would include sort of in some of the advice that we give caregivers is making sure that they're taking care of themselves primarily so that they can be good caregivers. Allowing them not to feel guilt, encouraging them in terms of, taking breaks and not having to feel guilty about that, or asking for help and being open to help in whatever way is available. Also encouraging them to, provide a level of care at the sort of level of the disease early on, instead of taking over and doing everything, sort of allowing the patient to participate in whatever level they're able to, allows for the caregiver not to burn out too fast, and just slowly over time potentially taking on more tasks as the need arises. I think overall, as providers, being open to the patient and their families in terms of goals and the direction of care, not always having a very cookie cutter approach is important. Every family has what they view to be sort of goals of care. One thing I haven't mentioned previously that I think is very important, as early as possible, identifying treatment objectives and also advanced care planning. It's a simple thing, but having that in place early on allows for a clearer path sometimes for as the disease progresses.
An advanced care plan is really not about being sick. It's about what to do when you can't get well. And most people just don't realize that we all have a plan. Even if you don't have a formal advanced care plan, you still have one. Because if you live in the state of Texas is happy to give you one when you don't have your own that's written. And it's something I call the default plan. Most people are just not aware of that. And the default plan says that your nearest living relative will step in and make decisions for you. The other myth I hear is, I don't want anyone to have that kind of power to make decisions over me. Sadly, what they don't understand is that 8 out of 10 of us will lose capacity at the end of life. 8 out of 10 times when people leave this earth, someone else has to decide for them when that time will be. So you can say, I don't want anyone to have that kind of power, but 8 out of 10 times somebody else will have it anyway. When we name someone we love and trust to be our agent or spokesperson in an advanced care plan, we are relieving them of the burden of actually making a decision. But we can prevent that extra layer of decision making by helping folks understand exactly what we would want at the end of life. If you have a living will or a directive to physician and family, 2 things have to happen before it speaks on your behalf. You have to be terminally or irreversibly ill, and you have to have lost the ability to communicate with us. If you have the medical power of attorney, then there's only one triggering device that needs to happen, and that is you've lost the ability to communicate and someone else can speak for you. In either case, it's important that your family knows what you want. That is the real genius of advanced care planning, and one of the reasons that I'm such an advocate for it.
There are many communication gaps that can occur from the office visit, the follow-up information, what sort of tests are being ordered, and the instructions that are being given. So many times having that in writing specifically for the patient and the caregiver versus just verbally giving that information. Also identifying, needs that occur between office visits, refills of medications and supplies, other orders that are needed, allowing the patient and the caregiver to have a contact person maybe in the office, a case manager, social worker, to help them navigate through other resources that they potentially might need, or other referral sources where they can be referred to, as well as, being able to report changes in their loved one's situation. There may be things that occur or situations that occur that require, sooner follow-up than planned, or a change has occurred that requires maybe a new level of care. So many skills that the professional needs to know about that we don't get in formal education. There are nonverbal cues, watching the patient and the caregiver, their silent interactions. Sometimes will speak to you in terms of, quick actions, the tone being used, the shortness in the speech, for example. There are also other areas that have to be watched for in terms of the physical health of the patient and the caregiver. Just changes that one notices. It is okay to, verbalize the changes that you note and ask a follow-up question. I noticed that this has changed. Why is that? And being open to that sort of line of communication. And also as providers, always sort of, giving the patient and the caregiver the feeling that you are willing to talk about any topic, not just the medications, not just the refill requests or whatever tests that need to be ordered, but also the mundane day-to-day interaction, and being also sort of physically, maybe not with our speech, but also just with our physical demeanor, being open and not in a rush, sitting down and having, eye contact and the interaction with the patient, even if they are nonverbal and at the end of their disease process.
The Medical Alert Safe Return is something the Alzheimer's Association is able to provide for those who have been diagnosed with Alzheimer's disease or related dementias. And so what we're able to do is that when they get that diagnosis, they're able to contact the Medical Alert Safe Return system. They can do it through alz.org or call our 800 helpline, and they will then register their new hopefully newly diagnosed patient with the disease. And so they'll give them, when they contact the center, they're going to give them information about the diagnosis, where they live. I believe a picture is attached as well. And so they have all of that information in the system so that if something did happen to them, if they wandered away or they became ill or they were alone, and a first responder or someone walked upon them, they would know how to find them. They would know what was wrong with them. And then we would know how to respond, how the first responders would be able to intervene with them. It also is not only wandering, but it covers things like health. So, for instance, if the first responder had come and there's other health conditions, because comorbidity is an important part of what we have to examine and look at, and we see it often. And so if the first responders come, it's not only a safe return, but the medic part of the medic alert safe return is their medical record. It's going to talk about, what medications are they on, and what information do we need to know about them. If they had a seizure disorder, for instance, it would be able to provide that information. You can get on the internet, and there are GPS locating systems for Alzheimer's patients. They do exist. I would just encourage folks to read and understand what it is that they're signing up for. They are likely fee for service for those items, and they would want to know and understand it. Silver Alert was passed, I think, in 2007 in Texas. Now, I will say it is state to state. For here in Texas, if they've gone missing, I believe it is 72 hours that you have to make that report. They do, and this is probably the most important part, you must have a written signed diagnosis by the doctor. So they removed the age criteria. The diagnosis criteria remains, and so you would contact your local authority. So you don't register, but because you have that diagnosis in your hand, you're able to make that report. And so you would call 911, and they're looking to their local jurisdiction. And the police, they're the ones that go in the system and file the information to get the information out there. And going back again to Medical Alert Safe Return, they work in partnership as well. So if that Silver Alert is going on, they're notifying the authorities as well. If the authorities are in communication with the family, and that family has that diagnosis on the paper, then that moves quicker.
Meals on Wheels provide services with regards to not only meals for the loved one themselves, but they provide other services and programs about medication reconciliation, behavior counseling, other forms of support. They even provide meals for pets as well, so the loved one won't give away their own food.
Dementia Friendly America is an initiative where we work to develop dementia-friendly communities across the United States. And I live in Fort Worth, so we have just kicked off our initiative in the city of Fort Worth to become a dementia-friendly community. So what that involves is looking at every sector of the community, not just healthcare, but neighborhoods, because most people with dementia don't live in residential care communities. They live down the street from us. So how can we as neighbors learn how to be dementia friendly? Businesses, restaurants. It's a way of looking at every sector of life, from government to healthcare, residential care, neighborhoods, transportation. How do people get around who have dementia? So it's all about helping every aspect of community life learn a little bit about dementia, and then learn how to be a dementia friend. And there's an organization called Dementia Friends USA, and you can go on their website and watch some little video clips that kind of demonstrate how you could be a dementia friend in certain parts of the community, in business and retail and restaurants and such. And then you can become a dementia friend because it helps educate you.
There are not enough geriatricians in this country. And as the population ages, there is a great need. But many family physicians will need to step into that role. Many internal medicine practitioners will as well. And so we all need to better verse ourselves with the care of the elderly to provide them good care, and good care doesn't necessarily mean a prescription.
Because I've been a nurse for forever. Doesn't mean that we know the latest information about dementia. Some of us need to relearn some things that we learned a long time ago, or get information on new things that we now know as a result of research. So I think learning from dementia experts who are up on all the research. Don't just assume that because I'm a nurse or because I'm a physician, I know the latest. Because there is a lot that's new, and the more new things that we learn, the better able we are to meet the needs of our folks that we're dealing with who have dementia.
Thank you for joining us today. We hope that you found this program helpful. The James L. West Alzheimer's Center is dedicated to supporting medical professionals, family members, and persons with dementia in their journey. We hope that you'll watch our other programs and that they are helpful to you, and that you'll consult the resources at the ends of those programs as well.